Hello, friends. I'm back today with a very basic topic. Yesterday, when I took class on novel stimulation protocols, many PGs and many consultants appreciated it, liked it, but they also said, "Sir, it was like watching Star Wars 3 without watching Star Wars 1 and 2. Will you please take the class on basics of ovarian reserve and their utility in controlled ovarian hyperstimulation?" It was like straight away going into the poor responders and how to treat them without really understanding the basics of ovulation induction and the ovulation reserve. So I have tailored this talk to address that. You also will have a question in basic science paper on biomarkers of ovarian reserve or maybe ovulation induction protocols and things like that, and or totally on the pathophysiology or physiology of ovulation. So that's why I thought this class would be more appropriate for you. And let us straight away jump into that. As the title goes, Biomarkers of Ovarian Reserve and their utility in controlled ovarian stimulation. I'll be talking under 4 headings mainly. Number 1 is physiology. Number 2 is biomarkers. Number 3 is clinical implications. And finally, I will talk on specific situations and special situations. First, let us look at the physiology. I have been always telling gynecology is menstrual cycle is gynecology. You must know this thoroughly. Without knowing or without understanding this hormonal cycle, ovarian cycle, endometrial cycle, and menstrual cycle, there's no gynecology for us at all. Much before that, let's start from the right in the beginning, oogenesis. It begins in the female embryo. Primordial germ cells differentiate into oogonia. At around 2 to 7 months, from approximately 1,000 oogonia, they divide to form 7 million germ cells. Easy to remember, 7 months, 7 million. That is 70 lakhs. From 7 to 9 months, most oogonia undergo atresia, and at birth, they fall down to 1 million, from 7 million to 1 million. Then what happens? The remaining enter the first meiotic division to form the primary oocyte. When they are primary oocyte, already the first meiotic division has taken place. The primary oocyte remains in resting within small follicles until puberty. By the age of menarche, approximately we'll have 400,000 follicles. But out of this, only 400 ovulate in a lifetime. From 400,000, 400 only ovulate, remaining will simply be wasted or they undergo atresia. Easy to remember, let's say the average reproductive age is from 10 years, that means the age of menarche, to the age of menopause, let's say again average 45 years, 35 years. Into each year, even if they ovulate 1 egg per month, 35 into 12 becomes almost around 420. You can remember it as 400. So this is in an unstimulated cycle. So this is the story of oogenesis. Let's now go to the all-important ovarian, uterine, and hormonal cycle, out of which I'll be only concentrating on the hormonal cycles today. And all of you know this is the one which I call the beautiful dancing of the hormones. Who are the actors here? LH, FSH, estrogen, progesterone. Of course, there are other players like inhibin and things like that. So all of you know in the previous cycle, I don't mind repeating it again and again, because no matter how many times you repeat, it is very, very important for us. It should come just like that from our spinal cord, maybe even from our lips, it should come. We should not be using brains to talk about this. So in the previous cycle, both estrogen and progesterones have gone down because there was no pregnancy. As a result, what happens? There will be secretion of FSH. The signal goes that there is no estrogen, no progesterone. So pituitary will first produce FSH. It will stimulate the follicles and the follicles will produce the estrogen. As soon as the estrogen comes, there will be negative feedback. This is a good daughter, I should say. So when there is enough of money, it tells her parents that enough of money, don't need to send it. So it will tell the pituitary, its father, shall I say, and enough of FSH now, there is no need of FSH. Side by side, another sister, that is inhibin. She's also a good girl, so she will tell enough of money, daddy. So now don't send FSH at all. So FSH goes down. But they not only say enough of money, now you send money to my another sister, let's say. So they'll give a positive feedback and GnRH is secreted and LH will come. Now LH surge happens, ovulation happens, and after that, under the influence of LH, progesterone is secreted. Let's say progesterone is a son. He's also a good son, so he will tell enough of LH, no need to send LH. So LH will come down. Of course, in the absence of pregnancy, I mean. So as a result, what happens? LH also goes down. Then, of course, progesterone also goes down. All hormones go down, FSH, LH, estrogen, progesterone, and finally, menstruation happens. So this is the normal one. We should understand this very clearly. GnRH, secretion governed by GnRH pulse generators in hypothalamus. It is secreted in a pulsatile fashion in the pulses of 1 in 90 minutes. But the pulse generator is released from suppressive effect of gonadostats between 8.5 and 12.5 years. So till such time, this pulse generator is sleeping in a deep sleep. So the suppressive action effect of gonadostats is released at this time. That's why there will be menarche. So average, maybe as I said, let's take it as 10. Regulates production and release of both LH and FSH in the gonadotropes of anterior pituitary. This we all know. Now, gonadotropins, mainly FSH and LH, they are important for the growth and development of ovarian follicles. You all know that. I'm going to talk more on two-cell, two-gonadotropin theory shortly. Synthesis and secretion of key hormones, that is FSH responsible for estrogen, LH responsible for progesterone. Induction of ovulation. You know that LH surge is the one which causes or induces ovulation. So there you are, two-cell, two-gonadotropin theory. That means both the cells are required. Who are the cells? Granulosa cell and theca cell. And both the gonadotropins are required, FSH and LH. So you can't say one cell is enough, one gonadotropin is enough. What happens is stimulation of theca cells by LH and granulosa cell by FSH required. Only at advanced stage will granulosa cells become responsive to FSH. What they do? They convert theca cell derived androstenedione into estradiol by that esterification, or what we say aromatization. That's where aromatase inhibitors will work in that way. And as I told you, in the case of PCOS, if that doesn't occur, granulosa cells will not produce estradiol. That happens under the influence of insulin, if you recall. So this is the famous two-cell, two-gonadotropin theory. I mean, this sounded like a very difficult one, tough one when we were PGs, but it is nothing there. So theca cells produce androgens. Granulosa cells will convert that androgen into estrogen under the influence of FSH at a particular time. Sex steroids, that is estrogen and progesterone, they are required, but when it is predominantly estrogenic intrafollicular milieu, it permits and favors follicular growth and development. So that's exactly why initially there should be estradiol or estrogen. So then only the follicles grow properly. Whereas if it is androgenic milieu, it will lead to degeneration and atresia. So that's exactly why if there is too much of LH, as happens in case of probably the PCOS, these follicles will definitely don't grow. They're all small follicles. They'll just maximum reach around 10 to 12 or 14 millimeters, and they undergo atresia. There is no maturation for them as such. They undergo like premature maturations in a way. So that's of no use. So what's the life history of ovarian follicles? As you can see here, there is initial recruitment. Whole lot of, I told you that 400,000 follicles will be there. So they are all there, but they are recruited months before they are finally going to be released. And that also is just like a lottery. So at a time, some 40, 50 follicles, they say, okay, I want to ovulate, I want to ovulate, I want to ovulate. And this is FSH independent stage. This occurs months before. So they all say, okay, I want to come, I want to come, I want to be ovulated. And okay, some of them are recruited, some of them are selected, and all those things happen. And then maybe in the recruitment, most of them are rejected. You are short, you are fat, you are this one, you are that one, and then one particular follicle is selected. Until this stage, the exogenous FSH is not going to act. So don't waste your time and money. That's exactly why yesterday, if you remember, the so-called mid-luteal phase FSH protocol failed, flopped. I put a big into mark at the end of the slide. No point in giving FSH before that. So after that, among the so-called so many recruited follicles, again, one only will be ovulated. In the bargain, so many sacrifice. It is somewhat like, to penetrate one egg, so many sperms will work very hard, but then only one will succeed, all others will die off. Similarly, the same thing happens. So one will always succeed, others will all sacrifice. So this is the story of the ova. Now, there are phases of follicular development. Full development takes around 220 days. It takes a long time, almost 7 months, as I just now told you. And it has got 3 distinct phases. What are the phases? Recruitment of resting primordial follicles. That is the first thing. They are all recruited. And then they are developed into pre-antral and early antral follicles. And then among them, there is a selection of single follicle, which is going to become the dominant follicle or Graafian follicle. And all these things, 3 steps or phases, are independent of gonadotropins. I'm repeating myself, but remember Dr. Padma Rao used to say, repetition is the essence of teaching. So when you keep on repeating the same thing in a different way, that it will just register in your minds. Follicular development requires not just FSH, that is follicular stimulating hormone, it also requires LH. Look at this. This is very important when you try to induce ovulation. You will remember this particular physiology. LH receptors develop in granulosa cells when they become 10 to 12 millimeters. And at this stage, they are not only responsive to FSH, they are also responsive to LH. They are granulosa cells, not theca cells. I know what I'm talking. So understand this. At this stage, FSH and LH equally effective to support and promote the granulosa cell function. So in how you will practically make use of this is, initially you give FSH injections, later you give HMG injections. HMG has got both FSH and LH. So when would you, if I ask you a question, of course we are not interacting here. If I ask you a question at this juncture, when will you give HMG? Your answer should be when the follicles become 10 to 12 millimeters. From that point onwards, I am justified in giving HMG, which contains both FSH and LH. I hope I am clear in this. Estrogen secretion and follicle development continue even when FSH is stopped or replaced by recombinant LH. That's the beauty. So estrogen will still be secreted. So it has got the memory, shall I say, because now LH anyway is going to secrete the from the theca cells, androgens come into the granulosa cells. Now granulosa cells basically respond to the FSH, but then after 10 to 12 millimeters, they also respond to LH because they develop the LH receptors, and then onwards they continue with their job of producing estrogen. Of course, granulosa cell knows only how to do estrogen. They don't produce androgen. But what I'm trying to say is they produce estrogen, even if you remove FSH or stop FSH and only give LH, because LH is also, after all, a generic name is gonadotropin, isn't it? So though it is luteinizing hormone, but it will stimulate the granular cells. So I'm underlining that word, even when the FSH is stopped. So suggesting development of larger follicle is completely independent of FSH. So that's exactly where most of the protocols, most of the centers, most of the infertility specialists, towards the end, they give some amount of recombinant LH. Also, it is going towards the LH surge, isn't it? So we are moving towards in that direction. That's the natural process that is happening. That's why I told you the menstrual cycle in the beginning. So towards the end, FSH is going down towards the ovulation and LH is coming up. So that's why, the final maturation of the follicle is because of LH and not because of FSH. So initially, yes, initial follicular stimulating hormone is very, very important, but afterwards it is LH. And towards the ovulation, of course, we all know it is LH and LH and LH. So that's where I am. The ovulation, it's a beautiful stigma they have captured. 24 to 36 hours after peak estradiol level. Obviously, when it is peak, it will tell the pituitary, stop FSH, stop. Now start LH. Okay, so LH starts surging 34 to 36 hours after the onset of surge. What is the practical importance of this? So practical importance of this is, when you want to do oocyte aspiration or ohm pickup, you have to give LH 34 to 36 hours before. So typically everybody gives, let's say today, if I give at 9 o'clock, day after tomorrow, that will become 34 to 36 hours. Around 8:30 to 9 o'clock, you will do the ohm pickup. So this is, we are trying to, in a way, simulate or emulate or copy the physiology that happens in the nature. 10 to 12 hours after the peak of pH, we are not going to look into the peak, and also I'm just graying it out. LH concentration must exceed the threshold of 14 to 28 hours. So that should be built up. Not only surge, it should be level should be maintained in order to ensure maturation. And LH surge lasts around 48 to 50 hours. So maturation plus ovulation both will be taken care of by that. So LH surge is typically continues in the meiosis, and expansion of the cumulus happens because of that. And there is also synthesis of prostaglandin, which is important for the follicular rupture and luteinization of granular cells. See, LH has got so many jobs. It has to make sure that the follicle matures. Continuous maturation means what? After all, it continuation of meiosis process, because later it has to meet the sperm and get fertilized. Expansion of the cumulus, so that the egg starts detaching itself from the rest of the follicle, and the prostaglandin has to be secreted, and egg is released. After that, the granular cells have to be luteinized, and it should induce or it should stimulate the cells to produce progesterone. And also it is like apne pair pe kuladi. Kuradi is saying that LH surge itself will act to terminate the LH surge, because it will stimulate the progesterone. Progesterone will go and tell that enough of LH. And it also helps in distensibility of follicular wall and proteolytic enzyme. So it has got so many jobs, but there is no need to remember so many things. They're all logical things. They're all chronological things. So maturation, then expansion, separation, rupture, coming out, making corpus luteum, making the corpus luteum secrete progesterone. All these are very logical things. So it should come to you very naturally. Now, having understood the physiology, I'll move on to the biomarkers. Now, if you ask me the biomarkers, yesterday I told you A for apple, A for apple. So A for, actually not apple, A for AMH, A for antifollicular count. But we must understand that quantitative markers have limited predictive value for pregnancy and live birth rates. These are all quantitative markers, isn't it? So we are estimating the AMH level, we are counting the follicles and all that. So clinical predictors of oocyte quality is lacking. We can only say how many oocytes are there. We can only say numbers and other things, but we cannot say whether this is a good oocyte. Only after retrieval will the embryologist will tell us. So as I said, if you want me to talk about the biomarkers, I can just finish the talk right away by saying A for AMH and A for AFC. Both are AA, like AA batteries or AA association in Western countries where they will help the automobiles. So A for AMH, A for AFC. But it's not that simple. Nothing is simple, especially the endocrinology is so complicated, or I would rather say so interesting. So different levels, they behave differently and the effects are different. So I have made another simple ABCD, not A for apple. So initially, as I said, there is a paracrine control gonadotropin independent stage, wherein primordial follicles and pre-antral follicles, and they become early antral follicles, and then they get into primary, secondary follicles. So all this happens without the help of FSH, but these follicles secrete AMH, and estimating them will tell us how many of them are there, how many can be recruited. So that is one of the important biomarkers of ovarian reserve. So A for AMH. Then B. So thereafterwards, what happens? This will produce not only estrogen, inhibin A and inhibin B. Inhibin A is produced later in the follicular phase. Inhibin B is produced in the luteal phase. Inhibin B is produced in the follicular phase. So that's the one you saw in the earlier picture, which will give a negative feedback like estrogen. So B for inhibin B. What is C? Of course, in the previous slide, I said A for AMH, A for antral follicle, but here I am missing the C. So I have just made a small change here. AFC ka C le liya maine, the last one. So ABC is AFC. Now, what is D? D for dimension or volume of the ovary. We did a thesis in Manipal, and that was regarding the volume of the ovary. If I remember correctly, it may be Dr. Shanta Kumari herself, but anyway, so that is volume, ovarian volume. And E for estradiol. I will talk in detail about all of them. Estradiol is a very, very important marker. In the early part of the cycle, it should be low. Just now we remembered the menstrual cycle. From the previous menstrual cycle, estradiol and progesterone both should be low. If they are low only, pituitary will feel that ovaries are hungry and it will produce FSH. If estradiol is enough, the pituitary thinks ovary is full of money, it is houseful, or it is tummy full. So estradiol is a very important marker. F for follicular imaging. Of course, follicular imaging goes with the antral follicular count, but not just that. Later, we want to, monitor these follicles, how they grow, whether they become primordial, whether they become graphene follicles, how many of them are there, whether it goes in for OHSS or follicular imaging is very important biomarker. And then, of course, G for gonadotropins, FSH. So this is the ABCD for you, my dear PGs. A for AMH, B for inhibin B, C for antral follicular count, D for dimension, E for estradiol, F for follicular imaging, and G for gonadotropin. New ABCD for you. Now, I will talk in detail about each one of them. Again, the caution. Today, if I cannot finish, because I don't want to run at all today, AMH itself can be a short note for you. AMH is a 30-minute talk on its own. And it's already, if I look at it, it is 7:54, and I have got hardly another 10-15 minutes. I will go on to part 2 maybe, but tomorrow there won't be any class because tomorrow there is Karnataka, our Manipal OBG Society talk is there. And whenever there's Manipal OBG Society talk, I must attend that and I can't be hijacking their time. The timing is same. So probably I will talk on Saturday. Okay, let me just go slowly. Antimullerian hormone exclusively produced by granulosa cells of late pre-antral, that is less than 8 millimeters, and early antral follicles. I have been using this word pre-antral and early antral follicles, but now another term is late pre-antral follicles, nothing but 8 millimeter follicles. Okay. So antral follicles, which are less than 6 millimeters, maybe, pre-antral follicles, shall I say, express greatest amount of AMH, So the most smaller they are, they probably express better AMH. And levels reflect health of granulosa cells. So a good amount of AMH means the antral follicles are good. That is the one thing. And then levels decline as antral follicles increase in size. You just saw in the previous slide, when they are 6 millimeters, they produce very good. 8 millimeters, they produce little less. And as they become bigger, it is not they have become follicles, they have become like big girls. And they will produce estrogen. No, not just, they will not produce AMH, right? So AMH is no longer expressed during FSH-dependent final stages of follicular growth. When LH comes, they almost forget their job. They don't produce AMH at all. So that has to be kept in mind. AMH expression disappears when follicles become atretic altogether. Now, initially, I was also a bit confused. If AMH is stopped, then we also say AMH can be estimated any time of the cycle. It doesn't depend on that and all. What is this? Later, it's so easy. I quickly realized that, yes, this particular follicle is becoming atretic, but there's another cohort follicle is waiting to produce AMH, isn't it? So always, yesterday also I told you, if you remember Shanghai protocol, what I told you, there are antral follicles in the follicular phase, as well as in the luteal phase, as well as anytime in your life. That is why there is always constant production of AMH. That's why there is no need to particular time to estimate this. Whereas when we talk about estradiol estimation and FSH estimation, we always say basal. Basal means day 2 or day 3. But for estimation of AMH, we don't say a particular day. Any day you can estimate, because any given day there is an antral follicle. But this particular antral follicle or this particular group of antral follicles, when they are small only, they will produce AMH. As they become bigger, they produce less AMH. And as they become mature, they will become atretic. There is no AMH. That's fine. But there are others who are producing AMH. I hope I'm very clear, and this has to be understood. AMH as a predictor now. Okay, this is very, very interesting. It's a marker of total primordial follicular pool. That's why we use it as a ovarian reserve, estimation of ovarian reserve. So if AMH is there, that means there's a good pool of primordial follicles which can be harvested. It's a best marker of ovarian function across clinical situations. It's not just the marker of the reserve. It will also give you a good idea about the ovarian function. So reserve is one thing, function is another. Okay, this is a very important short note, or it will come. Just an AMH could be a short note, 7 marks. So I have already had 3 slides. This is the 3rd or 4th slide I'm going. I have got few more slides on AMH. As I told you, AMH itself is a half an hour talk. Best marker for predicting poor or excessive ovarian response. Reserve, what are the words? I'm highlighting the words. Reserve, function, response. Predicting. So it will predict whether there is going to be a poor response. Suppose the AMH is less than 0.5 or even less than 1. That means you are expecting poor response. Yesterday you saw expected poor responders. When there is, the ORT, that is the ovarian reserve testing. And if it is high, means you get a higher response. So you can go in for OHSS or things like that. Levels decline as primordial follicle pool declines with age. Obviously, because all the AMH is coming from primordial follicles only. As the AMH decreases, it means that there's a decline in the follicular pool. It usually coincides with age. Suppose the patient is still young, that means she's heading towards premature ovarian insufficiency. So remember the words, it talks about reserve, it talks about function, it talks about response, it predicts rather, and the decline suggests that there's a decline in the pool. And it is undetectable at menopause. That's exactly why some studies have done that. You estimate AMH instead of FSH to diagnose menopause. But the studies have concluded that AMH is not required, though it is undetectable at menopause. Better still would be FSH estimation only. So then, AMH as a predictor is separate slide dedicated for this. Of poor reserve in cancer patients, in is repeated itself, forget it. Patients who have had significant ovarian injury from radiation or surgery. In fact, this can happen after a very aggressive laparoscopic surgeon who is going to take all the chocolate cysts and he's going to coagulate nicely to stop the bleeding and all that. You estimate the AMH after a couple of months, it will be very low. You don't have to go for chemotherapy or radiotherapy. So be careful while doing laparoscopic surgery for endometriosis. You don't have to be very aggressive. You don't have to nicely coagulate and things like that. AMH levels in women without infertility do not correlate with future fertility potential or the time to pregnancy. Suppose, let's say, she's not a case of infertility. She's a normal in the sense, I should not use the word normal. She is, let's say, a person who doesn't have any infertility issues. And if you do AMH in that person, so-called, let's say, normal person in the inverted comma, it doesn't talk about when she's going to become pregnant and whether she has got a fertility potential and all those things. In infertile patient, it is very important. It talks about ovarian reserve function, prediction, this and that. But in a non-infertile person, it is not useful. That's the meaning of this sentence. And should not be used to predict reproductive status or onset of menopause. See what I was telling in the previous slide, now it is telling. Don't use it for a onset of menopause, to determine the onset of menopause, or to say that, okay, you have a good AMH, so you are going to get good children and all that. No need. Don't waste your time on a person who is not complaining of infertility. AMH as a predictor of live birth. Slides are going on. Its diagnostic accuracy for predicting live birth is poor. So it should not be used to exclude couples from IVF and ICSI. It may talk about ovarian reserve, it may talk about ovarian response and all those things, but it is not going to say whether this lady is going to become pregnant or not. So many other things have to happen. The fertilization has to happen, and then the implantation has to happen, and then corpus luteum has to produce, and all those, so many things are there. So AMH, you don't stretch it to the level of predicting pregnancy, carry home baby, and whether the child will go to MBBS and all that. All right. So the threshold values for AMH, no consensus on the threshold value suggestive of reduced fertility potential. We say AMH is excellent, A for AMH, and all that, but then there is no consensus. What should be the value? Interpretation of AMH level is laboratory assay dependent. So obviously, in the world, there are so many labs, and, it will depend on that. No international standard. Therefore, clinicians should be guided by their own lab's reference ranges. So you refer to the lab report of your own lab and then take a call. As the level falls below the lower limit of normal, the probability of diminished ovarian reserve progressively increases. Of course, that's fine. Now, general guideline, I can say. I can't be giving you the exact guideline, but general guideline is that anything more than 3.5 nanograms per ml predicts a vigorous response to stimulation, and caution should be exercised to avoid OHSS. It's very high, 3.5 and more, you can anticipate OHSS, maybe a case of PCOS. More than 1, but less than 3.5 suggests good response. This is good stimulation. Earlier, I had made a gimmick of just remembering 1 and 3, but I have removed that slide because that's only for undergraduate students who have to just remember. Anything more than 3 is very high, anything less than 1 is bad, and 1.3 is okay, and less than 0.3 is bad. I just was playing with 1 and 3 and 0, but these are the actual values which a PG should know. Then 0.5 to 1 nanogram per ml is the baseline reserve with a likelihood of limited X at retrieval. This is just okay. just okay. But anything less than 0.5 nanograms per ml, reduced reserve with less than 3 follicles in IVF cycle. In fact, less than 0.3, better to straight away go for egg donation maybe. So as you can see here, it is the actual values less than 0.5 is reduced. 0.5 to 1 is okay baseline. Anything more than 1 but less than 3.5 is good response. Anything more than 3.5 is OHSS. So AMH versus day 3 FSH. I have not talked about FSH, but anyway, let's see how it fares. Unlike day 3 FSH, AMH can be measured anytime during cycle, which I have explained beautifully already. Demonstrates minimal intercycle and intracycle variability. There's nothing much there. It's all depending upon antral follicles. As growth of small preantral follicles that express it is continuous, not cyclical. Anytime there are antral follicles, follicular phase, luteal phase. That's what Shanghai people have understood nicely, and they are going for double stimulation. AMH fluctuations can happen in young women, lowest levels during very early luteal phase, and older women, minimal fluctuation over a menstrual cycle. Some fluctuation can occur, but then not so much. These are the only two situations. I think I can take this particular one, then I will talk more in detail about FSHLES. You have to know a lot about that, so I don't want to hurry. Inhibin B, okay, is, as I said, inhibin A is in the luteal phase, B is in the follicular phase, so it's a direct marker of ovarian reserve. You can say levels decline with the increasing age and poor negative feedback. It gives a negative feedback like estrogen, but it is not as good as estrogen to give a negative feedback. So FSH levels increase, when there is a low level of inhibin. Antral follicular count, I think I'll take this up tomorrow. Today, I will just stop this class because there's a lot to talk about antral follicular counts. It's not a case for hurrying up and, giving you the idea very drastically fast. Thank you very much. See you on Saturday. Tomorrow, no class. Why no class? Because Manipal OBG Society will otherwise sue me. Thank you very much. Bye-bye.